choice of antidiabetic medication for her are metformin, insulin, and low-dose aspirin. As she has underlying type 2 diabetes mellitus for the past 7 years, she should continue on metformin as treatment for her pre-existing diabetes to control her blood glucose levels alongside lifestyle modifications such as diet and exercise.
When metformin doesn't work, insulin needs to be added to control the glucose level. Insulin therapy is preferred during pregnancy since this drug doesn't cross the placental barrier, thus reducing the side effect greatly on the fetus. As there is increased insulin resistance in pregnancy, low-dose aspirin also needs to be administered. This is important to reduce the risk of preeclampsia as higher insulin resistance is directly proportional to higher risk of preeclampsia.
Pregnancy-specific hormones such as human placental lactogen and the increased levels of cortisol and prolactin increases the resistance to insulin, which calls for a greater production of insulin to maintain a homeostasis of blood glucose during pregnancy. However, in type 2 diabetes, the ability of the beta cells to compensate is impaired. The risk for maternal complications during pregnancy increases in diabetic mothers. Maternal complications include preeclampsia, preterm delivery, miscarriages, and diabetic ketoacidosis.
Pregnancy also can worsen long-term diabetes problems of the mother, such as diabetes retinopathy, that is, eye problems, which should rarely become active proliferative retinopathy, as well as kidney disease as measured by urine protein creatinine ratio and hypertension.
One of the most common fetal risks is macrosomia. When a higher amount of blood glucose passes through the placenta into the fetal circulation, extra glucose in the fetus is stored as body fat.
Observational studies also showed an increased risk of diabetic enteropathy, especially anencephaly, microcephaly, and congenital heart disease, directly proportional to elevations in HbA1c during the first 10 weeks of pregnancy. Besides congenital abnormalities, neonatal complications like respiratory distress, hyperbilirubinemia, and neonatal hypoglycemia could happen, and in the long run, the child will have an increased risk of developing obesity, hypertension, and type 2 diabetes.
For breastfeeding mothers with diabetes, there are two common medications options, insulin and metformin. Both have benefits and drawbacks but are crucial for managing blood glucose levels. Insulin, which is safe for lactation, may require more careful dosage adjustments postpartum due to increased insulin sensitivity. Customizing insulin regimens is important as lactation increases the risk of nocturnal hypoglycemia. Alternatively, metformin's oral administration is convenient and reduces the risk of hypoglycemia and adverse events, making it a suitable alternative for some patients. Metformin is often recommended for patients who find insulin injections challenging or have a predisposition to hypoglycemic events. The choice between insulin and metformin should be based on a patient's medical history, individual circumstances and preferences, and consultation with a medical professional is crucial in choosing the optimal treatment for diabetes.